Kia ora koutou, me karakia tātou, whakatakatia hou ki te uru, whakatakatia hou ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai. E hi ake ana te atākura, he tio, he huka, he hauhu, ti hei mauri ora.
Yeah.
No mai haere mai, welcome. Thank you so much for being here with us this evening for this session around intersex health for medical students with ourselves at Te Ngākau Kahukura and our friend Jelly from Intersex Aotearoa and in association with the New Zealand Medical Students Association. I'm Moira Clooney, I'm project lead for Te Ngākau Kahukura, and I'm going to pass over to my colleague Joey to talk a bit more about the session this evening.
Kia ora, thank you, Moira. And thank you, welcome to this webinar on an extremely stormy evening. I don't know if it's stormy everywhere in Aotearoa, but right now I'm in West Auckland and it's like very gale and gusts of rain outside every 10 minutes. So thanks for the people who've braved the weather in a kind of online context. We really know how busy and tired you must all be, and we appreciate you being here. As Moira said, this is a webinar hosted by Te Ngākau Kahukura and Intersex Aotearoa, and we're going to introduce ourselves in a minute. Our panelists here will introduce themselves. But I wanted to just set the scene to say the general gist of what we are trying to achieve in this webinar. So it's not going to be a nitty-gritty medical, clinical, deep dive into that side of things, because that's not our expertise. That's not what we're bringing. That's somebody else's job. We really feel like there's a need to talk about current dynamics in intersex health and human rights on a big picture level, on a kind of national scale. This is something that went into the recent 2022 budget from the government. There's allocated resources to implementing something about human rights and intersex health, and we want to see community-led responses to that. We really feel like community organizations have a lot to offer in that space. And that's partly what we're bringing to this discussion with all of you today, and hi to those of you who are watching this as a recording. We really feel like you have a role to play as medical students, as people training in any kind of aspect of healthcare, to transform our health system or be part of the transformation of our health system. We're not laying this burden completely at your feet by yourselves by any stretch, but we know that you have different ways of doing things than other people might have, just by virtue of having grown up in a different context than people who are maybe in more established roles in the medical field. So we appreciate that it's a hard thing in a context of a hierarchical system to really challenge it, but we are here to support you any way that we can and provide resources and support to ensure that you feel like you can talk about intersex health and talk about human rights, and you don't have to be an expert, but feel more confident in that space. That's kind of our push for this webinar. Before we all introduce ourselves more, Jelly, is there anything about why we're here talking to medical students that you wanted to add to that in particular?
Well, I'm excited just to unpack this more and have the conversations that are about to. I think that's a really beautiful context that you've laid out for us. So thank you for that. Welcome, Matt.
Cool. All right. Well, I can start us off as a round of introductions, perhaps. I'm Joey McDonald. My pronouns are they, them. I am currently working and have for the last few years as the education lead at Te Ngākau Kahukura. We don't want to take up lots of time talking all about the ins and outs of our organisation. You have registered and you've been to our website. You can check it out. It's great. I'm based out in West Auckland, as I was saying, on the whenua of Te Kawerau Amaki. This is also where I grew up. I'm a Pākehā person. Mostly I whakapapa to Scotland on my dad's side. That's the McDonald's of Glencoe, and my mum's side's mostly in the UK, the Croftons of Essex. Yeah, I am keen to learn more. I learn more every time Jelly speaks about intersex stuff, and I do a lot of work in terms of trans healthcare and gender affirming care, and there's a big overlap there with intersex healthcare, but it's not the same. So I learn a lot, and I'm excited to be here doing that. Am I maybe passing to Jelly next.
Sure. Thank
Cool.
you so much. I love working with you all, and it's been so great building a relationship with Indira this year as well. So thanks so much for coming along on the ride with us. Yeah, so Jelly, she, they pronouns. I am the communications and project manager for Intersex Aotearoa. And I am here in Te Whanganui-a-Tara. We've got some pretty serious storm clouds building up. Supposedly there's snow on the way. I don't know, pretty exciting. We will see. Yeah, and I am an intersex person with lived experience, and I've also have lived medical experience. I've lived experience of being medicalized. Is what I'm trying to say. I'm not training as a student. So I come from that position of lived experience, and now also work advocating on behalf of others. And I'm really proud to be in that role and with you tonight.
Thanks, Jelly. It's awesome. Awesome to have you here. Indira, can I call on you to introduce yourself next?
You absolutely can. Kia ora, ko Indira toku ingoa. I'm also in Pōniki, where I can confirm it is raining. I'm just a little bit wet from coming in from the rain. I'm a fourth year medical student at the University of Otago Wellington campus. I'm also lucky enough to be the incoming Vice President Advocacy for NZMSA. And I've been working over the past year with these wonderful people to try and deliver this webinar for you guys, and also to hopefully deliver further education to other people in the medical space. I've done previous work around trying to increase education around minority groups, specifically the rainbow community, which, as Joey said, has some overlap with the intersex community, but obviously isn't entirely the same thing. So again, I just want to reiterate what's been said, that these people are all so fantastic, and I learn so much every time I talk to them, and they are just such fonts of knowledge. And I'm so excited that all of the people here tonight and all of the people who will watch this later get the opportunities that I've had to hear them speak and to gain from their wisdom. So I don't want to take up too much more time.
No, that's nice. Now we've all got good feelings about doing this work at 7:08 p.m. Moira.
Kia ora. Thanks everyone. Ko Moira Clooney toku ingoa, he uri tēnei no te raroa, ko mai te whotoki mō te karaka te hapu. So Moira, whakapapa to the Hokianga up north, as well as to the other side of the world, Scotland, England, Ireland, Orkney, the Shetlands. My pronouns are they, them. I am also in Tamaki Makaurau, same as Joey, but I'm in central Auckland. I'm just around the corner from Eden Park, where I hear the Women's Rugby World Cup is happening this weekend. I get notices in my mailbox when big games are on, so I can pretend to be up with the sports. Yeah, excited to be here tonight. I've been working alongside Intersex Aotearoa for lots of years, really, in my current role and previously when I was working in the mental health promotion space. And we've hosted a couple of webinars with Jelly over the last couple of years. So yeah, really excited to be here to hear from you again, my friend, and to talk more about how medical students can be part of this mahi with us.
Yeah.
Everyone.
Cool. And as Indira mentioned as well, we probably will be doing a couple more webinars when TBC the exact date, but sometime early next year. I anticipate March, April maybe, and they'll be advertised through NZMSA also, but it will also be a wider call out to other health professionals, whereas this one's really aimed at medical students, but there will be the Council of Medical Colleges is another element of this collaboration, and we're going to do some promoting out to their colleges and their members too. So you'll get multiple chances to hear from us. It'll probably be slightly different every time because we do quite a lot of improvisation. So you always get something a little different. I'm going to tell you some practical things that you might need to know about asking questions and things like that. Excuse me. So if you're attending live and you want to ask us a question, please feel free to put it in the chat at any time in this webinar. We'll be trying to keep track of that as we go along. Yeah, see, people are already having a little interaction in the chat. That's very nice. We also have the Q&A function, which you can put a question in there and it'll come to us. You have the option, I think, of making that anonymous. So if you were feeling a bit like, oh, I don't know if this is the right wording and I feel uncomfortable about putting it in a place where other people might see it, or, you know, in the chat, you can also just send it to us as panelists if you wanted to. There's some options there for how you might want to deal with it. We know that generally medical students often feel a little worried if they don't already have the answer to the test, and this is not a test. This is us sharing information with you, and your questions could be very, very helpful for us, not just in this moment, but we might get time to answer them. We are making time at the end to answer questions, but it will guide our future work as well. If we get questions that help us think, oh, this is the kind of thing we need to be covering, that can help us when we do future education work. So please do comment and put questions in the Q&A or in the chat. We are recording this webinar, as you might have noticed, as you will certainly know if you are watching this as a recording, and that means confidentiality is particularly important to us. We won't be sharing any information about any specific people, and we ask that you don't either. Privacy and confidentiality obviously are things that people working in healthcare know about, right? We know about how to manage that. This is a professional development opportunity, not a discussion about particular patients or particular family members or anything like that. Yeah, I think that's all I had to say about practical comments, unless anyone else has any things they'd like to throw into that mix amongst my panelists. No, good, great. We're gonna have a little bit more chat, then have a presentation from Jelly, and then kind of have discussion and questions. So that's the broad structure of our time together. I'm going to pass over to Jelly and Moira to talk a bit about language, I believe.
Yeah, kia ora, thank you, Joy. And Jelly, I think you've got some slides to share with us. Wanted to get into some discussion around kind of what is it that we mean when we're talking about intersex. Can I pass over to you, Jelly, to talk us through that?
You are currently muted, Jelly. Classic.
It's because I had too many tabs open. Yes, thank you. So I just wanted to make the distinction that's really important about what we're talking about when we're using the word intersex in this moment, and that there are some other distinctions that could make this a bit confusing, seeing we're speaking into a healthcare context. So from a community perspective, so those with lived experience, intersex is an umbrella term that covers a wide range of variations, and so there's up to 40 of those, and they're about 2.3% of the population, and so they could affect any of your primary or secondary sex characteristics, and the difference between maybe what a medical pathology would deem as intersex are those that are just the variations that are seen as between sex. So for example, they might have a chromosomal difference. So 46XX or 46XY are some of the variations that are deemed truly intersex. So I actually have a variation that is not deemed truly intersex, but my theory is, and it's an important one in this case, is that I get to decide. So it's just really good to think about some of those hierarchies when we're talking. And I'll share the next slide, and that actually goes through at the bottom there, we have a few of, when I say a few, a bunch of different variations and the diagnostic terms that those are used. We also have a range of terminology that's thrown about, and I've taken the liberty to put in the purple the ones that I'm going to give a double thumbs up, and the ones that are in pink, I'm going to say maybe it's a good place to start just not using those, especially hermaphrodite got phased out in the early 2000s with disorders of sex development. We're going to also say, you know, let's not say disorders. If you have to, say differences, but you could also say variations. And yeah, I guess I don't really need to go into that more, but there is acknowledgement within the medical fraternity that times are changing and the language needs to change with it. Oh, and I skipped to the end of the classic. And then we were going to talk, and Moira, jump in if you want to say anything about this, but we wanted to raise, you know, how intersex fits within a rainbow context and the importance of the differences and distinctions that make up the groups of that. And I guess intersex is there primarily because it challenges social norms, and this makes those with intersex variations vulnerable to discrimination. And so the same things that drive that discrimination, so it could be interphobia, transphobia, homophobia, are the same things that, you know, heteronormative, patriarchal and colonial norms that affect other people within the rainbow. So I guess what we can do together as peers, as peer groups and communities that make up a community that is the rainbow, is you know, there's that peer allyship where we're all calling for bodily autonomy and self-determination. Yeah, and then also, however, lots of people with variations of sex characteristics would not perceive themselves as part of the rainbow. And this is for many reasons, which actually could probably be a whole other presentation. So we won't go into that now, but I just really wanted to say, don't make assumptions. Again, use your words, check in with people about how they like to describe themselves and what language they use. Did you want to say anything about that, Moira?
No, I think you covered it really well. So I guess, yeah, I mean, I guess from a the perspective we're talking about around intersex, we're talking about, you know, intersex is about natural variations in people's bodies. It's not being intersex isn't a medical problem, but might come with medical considerations or medical needs. So I guess that, yeah, would that be right in terms of the distinction that you're making there?
Yeah, for sure.
Yeah.
Yeah. Cool.
That's great. I mean, I think it's always helpful to set ourselves up with a bit of language. And I also want to reassure people that you are going to get all of these slides. So we'll put them up on the website, and we'll also send them out to everyone who's registered for the webinar. You'll automatically get them. So don't worry if you're not able to retain everything that's being shown in front of you right at this moment, because it will be made available to you to go through at your own leisure, as well as the recording. Cool. Okay. Well, the next thing that we are going to do is ask Jelly to continue sharing slides and kind of do the presentation part of this webinar, and then we'll have some more time for discussion. I've already had a couple of questions come in, so I appreciate that. That's lovely and helpful and on point. Thank you. Jelly.
Thank you. So I had fun putting this presentation together, but I also really got my nerd on. We're not going to have time to really deep dive into every point I bring up, but as Joey just said, you'll get the slides. And I guess part of that is because the history of medicalisation is complex, and, you know, there's a lot there to sift through. But I think it's really important that we start here, because sometimes to move forward, we've got to look back. And so I'm not looking back. I'm just starting around the mid 1950s. So yeah, we're looking at a post-war landscape where surgical technologies have become refined through war times. And the most important, I guess, name that you'll hear or maybe discover in research around intersex medicalisation is Dr. John Money, who's actually New Zealand born. And he did a lot of experimentation and development around I get what theories can be around gender and how this could be placed on different bodies. So the guidelines that he created in the 1955s actually recommended that you could create a consistent rearing of a gender of a child if there was ambiguous genitalia. So the beginning of a power position was emerging in the 1950s that said that with ambiguous gender, ambiguous genitalia, you can, as a parent, decide what gender your child will be. And this really set us up into what became a blurring of medical interventions as a form of psychological support. And I've got a quote here that you can read that talks about these young people with CAH, and that once they pass through an operative process, not only did they revert to their normal feminine traits, but they also...
I didn't get that. Could you try again?
Sorry, that was Siri. They also were able to overcome what was deemed abnormal sexuality. And that's really true to John Money's writings, and is clear in a lot of the text, is this fear of sort of the diverse body leading to a diverse sexuality. And through John Money's work, he really was able to use surgical intervention as a tool for his psychological studies, with pretty devastating results. And so with this idea that you could fix what was a problem of diverse bodies sitting outside of norms, the best and easiest way to do that was to make it a childhood issue. And so from the 1950s on, we saw a ramping up of technologies and methods that led to this. And yeah, I really want to point out the fragility of childhood psychological development as a justification for early intervention, because that's still something that hasn't changed in terms of a motivation, as well as the parental anxiety that is also invoked as a threat. So these are things that are rationalized in early text, but are still with us today. And so in these surgical technologies, the social norms prevail. Again, hyperspadias is one of the highest amounts of surgical interventions in Aotearoa today. And the rationale here is this doctor in the 1950s is talking about how important it is that a boy at school should pass urine like his fellows, but because this is for psychological reasons. You know, and it's a cultural concept, right? Standing up to pee. It's not a health issue. It's not saying this boy couldn't urinate, was having problems with urination. So again, the literature from this time shows that these early pioneers of intersex pathologization were responding to, you know, personal fears around diverse sexualities and diverse embodiments, and this idea that if you edit the body, you can edit the mind. So here, and using heterosexuality as a measure, one that is linked to strict patriarchal and colonial notions of normality, bodies are structured into a binary of how to be male and female. And, you know, it begs to ask the questions, if 2.3% of the population have a variation of sex characteristics, like what is normal? And in the literature with these early recordings, there's not a lot that goes into the health concerns and a lot that goes into the social concerns. And then we've got this quote from Alice Dredger, who is one of the sort of supportive academics from the 90s that really came through and started speaking on behalf of community and the academia to fight against this pathology. And here she says, surely it will be familiarity rather than knowledge that finally takes away intersexual supposed strangeness. I thought that was important to talk about how we got where we are. And another thing that got us where we are is colonization. And I would be remiss not to speak about that. So many hapu and iwi have stories that tell of tupuna that can be understood now as having intersex variations. And in that pre-colonial realm, all members of the whānau were accepted as they are. So, you know, not only did colonization bring British settlers, but also values, norms, and knowledge systems. And that includes, of course, scientific and medical systems. And I just wanted to shout out to Dr. Elizabeth Kirikiri's doctoral research on takatapui and Intersex Aotearoa's co-chair To Chapman's journey as she emerges era tangata as a te ao Māori concept of intersex. And I wanted to speak really quickly about the link between trans and intersex healthcare, because from that early start in the 1930s, there was a kind of a conflation and also a medical boundary drawn between the pathologization and the sort of natural and unnatural concerns and fears around both those spaces within medical settings. And I thought this quote really summarized that well. Even after years of criticism from intersex people, many providers are quick to perform surgery on bodies of babies and young children that they consider abnormal. At the same time, they hesitate to act in cases where trans individuals request surgery. What is that tension about, right? We've got a community being over-operated on, and then we've got a community who is calling for bodily autonomy by affirming through medical healthcare, and it is being denied. So the pathology today, unfortunately, lots of those psychosocial motivations that I've explained remain the same. There is limited teaching in medical colleges in midwifery and sexual health and relationship and education, though hopefully we will see changes in that over the next few years. We have seen surgical techniques. To be fair, there's been a lot of change, and I've put in a quote there that I won't explain now, but you can look that up to make a whole rather than a poll. We're having real issues getting data, and lots of those across different DHBs is because there's not any real method around diagnostic terms, and I guess the way that people record what the surgical interventions are, but we do know that it's, you know, a distinct number. We have a overarching kind of dominant approach of a genetic analysis as being what deems whether something's intersex or not, and on the Starship Hospital link at the end, it can take you to some of the ways that some of the kind of processes or medical measurements that are made on young infants' genitals, which are deemed like clinical objectives and rationalized subjective differences. We still don't really have a proper overview of what's actually happening in our New Zealand hospitals, but we are seeing now internationally the encouragement of multidisciplinary teams, including those with lived experience and psychological support for families and young people. And I just wanted to shout out that, you know, this is a discussion about being the change, and one of those methods is through a human rights framework, and in this case, and it's important to talk about the United Nations and their the committee's request to the New Zealand government, and there's a list there of observations where we need to do better. I wanted to speak to decolonisation, that always should be brought up in any dialogue about demedicalisation. You can support the call for resources for healthcare training and development, and make sure that these include in community-led education and advocacy. And that a lot of our surgeons that work in this area, they actually train in Australia, and what's happening in Australia around legislation and prohibition of medical interventions may have an impact on what happens here. So, you know, look to see what's happening in the ACT and Victoria around that legislation. It's really interesting. And that's been massively led by community activists. And yeah, I think I've come to the end of the slides. I've got a few resources here that I wanted to shout out to as well. If you want more information, those are all in a clinical framing. So they're not necessarily ones that I always share, but I think they speak to a language that's relevant to the people we're talking to today. And it's a really great start. And again, like the Starship guidelines were informed partly through the clinical roundtable, and they're not perfect by any means. And I don't think the people that helped develop them would say so, but it's a vast improvement of where we've been. So it's important to have a look through those and see that there is attempts to change language and approach and bring in some of those things like psychological support for families and young people where there wasn't before. So I'm going to stop sharing screen now.
Oh, well, you're perfectly on time. That was beautifully well done. I appreciate the nerding out. I think that's quite relevant to your other panelists and to our audience. And I think maybe the links that you put in your slides, we might also put up on our website separately as well. Maybe with a caveat, as you said, that we're not endorsing them as perfect, but they are a place to start, especially if you're thinking from a medical context about what the current information might be. We've already got some resources up there on our website, on our page, and those are ones that we feel very confident about because they come from more of our community perspective. Yeah, it's not always a harsh tension between those two places, right? But it can be a harsh tension. So I'm going to let you have a little breather, Jelly, before I slam you with a bunch of questions. I was actually going to ask Indira to field the first question, which comes from your panelists more than from your audience, but I think is directly relevant to your audience because we want to know, what do you think, given this context of talking about intersex healthcare today, what do you think the role is for medical students in particular?
I think that as medical students, all of you listening to this will groan when you hear this because I'm sure it's something that's been told to you a million times, especially for my clinical colleagues, that we have a huge amount of time. I can speak from personal experience of today that I spend a lot of time just sort of sitting on wards, not doing a whole bunch of stuff. And it's really great when you're in clinical settings to have that time and to be able to talk to patients about things that are relevant to them. Everyone who's been in a hospital knows that it's all go, it's totally slammed. Doctors often don't have time to talk to patients about things that are important to them and could be relevant, such as community groups that they can speak to, places to get additional resources, that sort of thing. And if you're aware of the resources that are out there, you're aware of the information that groups like Intersex, Aotearoa and Kahukura are providing, you can pass them on to patients. And often patients will ask you, for those of you who are preclinical and haven't done the scary hospital stuff yet, patients are always asking for advice, for resources. Where can I go to find out about things? And it's great if you can then say, actually, I know where you can go, and connecting them with community and being that sort of change in medicine. No one's asking you to run into operating theaters and, pull your arms out across, a operating table and say, no, don't do it, or anything dramatic like that. And it's obviously really hard when you're in a situation and you feel like something isn't going right and isn't going well to speak up, because consultants are super scary. But talking to patients and advising them on places where they can get resources is a huge one. But also, when you do see things going wrong, being able to identify and be confident in yourself that what you're seeing is wrong is a really great step for your own practice, because I think sometimes we're conditioned to think consultants have all the answers. They're doctors, so they must know. And we doubt when we know something's wrong, but they're doing it, so it must be right. This sort of thing is great for you, so that for all of us, so that we know, no, I'm right, to feel like this isn't okay because what's happening here is wrong. It is invalidating of this person's identity. It is dangerous for them and their health. And knowing that then gives you more confidence to potentially do something about it if it's safe to. And that might be saying to the patient privately, are you okay? Are you okay with how this is going? Advising them about their rights. It might be reporting, health practitioners who aren't acting in their patient's best interest, raising awareness about those issues. It might be general things like speaking to hospitals about their guidelines. Those are all areas that, once you have more confidence in this as an issue, there are things that you can look to do. And, there's lots of things that need doing. And so depending on where you feel your confidence lies, there's different things that you can do. So I think the role for medical students is really diverse and full of great opportunities to make even just small changes. And across the board, not just for intersex patients, not even just for minority patients, for patients in general. They think we're the bee's knees. They think we're so smart. And it's so strange, because I don't know about you guys, but I am always like, no, I'm not. Please don't put that on me. But yeah, they're so excited when you want to be involved in their care. And this is just a great opportunity to be more so for our intersex whānau.
Thanks, Indira. Yeah. I liked the visual of someone running into an operating room and throwing themselves in front of that situation, but I recognize that's not actually what we're asking people to do. But there is something about changing narratives and changing discourse that happens incrementally and also happens because people just constantly are changing the way that they're talking about something and changing the way that they accept other people talking about it. And I feel like that's the paradigm shift that we're hoping to see, where it's no longer acceptable to talk about intersex people in a pathologizing, limited to only a medical diagnosis kind of way, unless that person is requesting that and that's how they want it to be done. But it's making sure there are more options for how people can be engaged with and what options they are given as part of their healthcare, because community support and social support, peer support, we can't say, oh, there's millions and millions of groups that you can find, so much support available, so much funding. It is a little bit hard going sometimes to find where the support is. Intersex Aotearoa is a great starting point for a lot of finding out where more specific groups might be. That's what we would recommend at Te Ngākau Kahukura. Yes, okay, thanks, Indira. I think I want to bring us back to talking about human rights, because that was one of the things that we promoted this webinar as being about. And I feel like, Jelly, you obviously did the deep dive into the history of how we've ended up in a situation where we're trying to move away from pathologizing and towards a human rights framework. Do you have any insights for people who are going to go and work in healthcare settings in some way, for what that means in their practice? Like what do we mean when we say human rights? Like, obviously we don't just mean you go around saying, hello, I respect your human rights, have a nice day. Like, what does it mean? Do you have a thought about that?
Yeah, I think, I would hope that people in training are hearing like terminology like patient-centered care or person-centered care a lot more, and informed consent, bodily autonomy. But I really want to make sure that we don't just think of those as terms that are passive, but they're actually active and they mean really different things to different people. So, you know, someone's bodily autonomy might be like making sure that their whānau are with them at all stages of while they're in a hospital setting, or, you know, for a young person, it might mean like actually just giving them the time that they need to understand and reckon with the loadedness of all these things. Yeah, it's a huge and ongoing and shifting, changing concept, but you know, if we really dig down into what every single person's own experiences of what it's like to be disempowered, to feel like that you're in a situation where you don't really understand all the things that are going on, but you don't really feel empowered to change that. I think we need to put ourselves in that position when working with others. I know that, you know, that we're talking about a time poor environment. And so maybe, yeah, I'm not wanting to be unrealistic about how much you can provide people, but when Indira, you were just talking about speaking with patients, like I remember those people that spoke to me. Still now, years later, I would remember them on the street, and I would be that person that's like, you don't remember me, but I remember you, because you know, those people make such a difference. They really do, especially when you're having a crap time. So yeah, use your privilege, use your position of authority, and whatever tiny way you can, it really, really helps. And yeah, there might be a time when those small steps along the way finally lead you to jumping in front of the operating table. But you know, you don't have to do that tomorrow. You can work your way up to that.
It's good to have goals.
Yeah.
I feel like we always have so much to say in such a small amount of time, but I do have a question for Moira, because I feel like you have a particular background and expertise in mental health sector, broadly speaking. If we're talking about intersex people or people with variations of sex characteristics, making sense of their experience, how it works for them and not being forced into a medical context. Do you have anything to add about mental health support, psychosocial support, the need for that as part of this picture?
Yeah, absolutely. Yeah, listening to your presentation, Jelly, that was just such a striking reminder about some of the history of these medical interventions being seen as psychological support. And I don't know that there's really ever been actually evidence of that being a good approach. I think it's been more people thinking, oh gosh, well, of course, you know, boys need to be able to pee standing up, otherwise they'll be ashamed or they'll be teased or something like that. I don't know that there's ever been particularly robust evidence base around that. I guess what we know in terms of intersex mental health, there's sort of a general lack of research and evidence, but that the intersex people do generally as a population have higher rates of mental distress, and like some of the research from the States is around also higher rates of trauma and sometimes manifesting as PTSD. And that's not because there's anything inherently shameful or bad about being intersex, or that would have to be the case, but that people can be subject to kind of judgment and discrimination. There can be really tricky family dynamics. I think part of that pathologizing model has often been about kind of secrecy and shame as well. The idea that you pick a gender for a baby and then bring them up as that and don't really tell that, like the model used to be that you didn't really tell them what was going on with their body or what their history had been about. So obviously like that secrecy can really be harmful, and then the actual impact of medical interventions as well, and kind of being over examined and over pathologized and things like that. All of those things can combine and can really impact on mental health. So I think part of what's important in this space is being able to have access to kind of mental health professionals and support who can understand some of that context and who don't see being intersex as the problem, but can kind of understand some of that context of where people are coming from, and not making the patient educate them about what being intersex is, or what that might mean. But I think the other side of that question to me also is about peer support, and if you're making sense of your own experience, just the huge value of being able to find other people who've been through similar experiences to you. That's one of the biggest things I've heard about from intersex people in terms of making sense of their own experience and coming to like conceptualize what language they might want to use about themselves, or how they see their bodies, or how they see their lives as being able to connect with other people who have been through similar things. So I think that's a really important role for medical professionals, as well as being able to connect people up with peer support and with community organisations like Intersex Aotearoa, maybe online resources. And I think, something else I've heard sometimes from people is this common experience actually of being told by a doctor that you probably won't meet other people like you, that what you have is really rare, and that it's likely that you won't find anybody else. And that's not, isn't necessarily the case, even if somebody's variation is really low prevalence. It's much more possible to find people online these days, and to make those connections. So I think, that peer support and that being able to connect for a person themselves, but I think also for their whānau when a young person's growing up, being able to connect with other people who might have some of that similar background is super important in terms of mental health.
Yes.
Yeah.
Yep. And the slides that Jelly was sharing earlier with like lists of medical conditions, or how it gets framed in very medical language, that's part of that disconnect, isn't it? That like you don't think community support exists for this medical condition necessarily, and actually there really might well be a Facebook group full of other people talking about that experience that they've had. Or if not, the Intersex Aotearoa might be the perfect place, but half the time people aren't connecting that medical terminology that is being used with the concept of being intersex, and so those two things stay separate, when we're really hoping that they'll be more connected, and that medical students can be part of making that connection, that when you hear that kind of medical language, you'll know, oh, that can open up that intersex community support tab in my brain, and even if I don't have all of the answers, I can probably find some places where people could find a bit more information. Yeah, Jelly, you unmuted.
Yeah, I was just
in.
really pumped by everything that people are saying, and nodding so much that I thought I should use my words. Yeah, thanks, Moira, for explaining that arc of experiences and some of the outcomes, and then some of the kind of tools that can be used for connection and peer support's definitely so exciting, and something that we're going to be working on as an organisation over the next few years, and we'll obviously let everyone know in the whole of Aotearoa whether they like it or not when that rolls out. But yeah, just to also grab that point you were saying, Joey, about the sort of like the power of terminology, and then the political kind of gatekeeping that can happen around that, and that feeds into why some people don't see themselves as part of the rainbow, because they don't actually necessarily know that their particular diagnostic term links to intersex, links to the rainbow, and so there's a lot of kind of spiraling around in that isolation and shame that Moira is talking about for years. So people don't necessarily have to then go, oh, I'm going to use the word intersex to explain myself, but it's just another tool to get you there, to get more information, to kind of go, oh, I'm not alone. Oh, maybe I'm not a total weirdo. Oh, actually, maybe this is more normal than I realize. And that's so empowering, eh? Yeah, that's really cool.
We have a question that I think is quite relevant as well, about someone thanking you, Jelly, for your discussion, and also saying, we know that intersex children are vulnerable to unnecessary interventions, right? Being overserved by medicine. And then on the other hand, do you think there are instances in adult life, later life, where intersex people are being underserved by the medical field, like similar to what you were saying about trans people seeking gender affirming care? and not being able to get it. Do you think the same thing is happening with intersex adult people?
Yeah, I think there's a few ways that I could answer that. One is that maybe a lot of specialty has gone into perfecting some of those surgical interventions and not so much on the genuine healthcare concerns. So we have adults who might have, for example, had their internal testes or gonads removed, but then have not been given adequate hormonal replacement therapy. So later in life, they're actually, having degradation of their bones, for example. So yeah, there's another part of the puzzle there where we really need allies within healthcare just to support like the natural functions of our body. And those don't have to be about us performing our gender in a tip-top way, it's just about our well-being. But also I want to just underline that adults also are at the brunt of pathologization. So this idea that only young people are vulnerable is not true. We do have adults that are told that essentially there's a medical emergency, that this disorder's been detected, but hey, don't worry, we can fix it, and it won't be until years later that people go, oh wait, was there really a risk of like cancer, or what actually just happened and why? So yeah, there's a lot to that question. It's a great question, and I could keep going, but I'm conscious of time. But yes is the answer. And
and it's so often about something to do with whose authority and whose power is being affirmed by that intervention, right? Less about the health and well-being of that person, more about preserving some sense of normalcy for other people. Exactly. Hopefully we can overturn that with this. There are new waves of people going into this health workforce that would approach it differently, I think, from the get-go. And even if you have to do an uphill battle, struggle against your colleagues, particularly possibly struggle against the medical hierarchy that's so strong, we will so appreciate anything you do in that direction. It will have an impact. Even if you don't see the impact at the time, it will have an impact for someone at some point or on the system as a whole. We have reached that point where I want to just do a final wrap-up round to hear from each of our panelists and then hand it over to Moira to close our webinar today. I don't really mind who does our final thought first. We can each have our final thought. Who would like to go first?
I've already got one. Is that okay if I
Great.
go? Sorry, I know I just spoke. I was just thinking just about our collective responsibility to make the change. The onus is not just within healthcare settings. You can remove the over medicalization and the pathologization. You can engage with people using informed consent and celebrating their bodily autonomy. But we've got a piece here about just the re-emergence of celebrating diverse bodies of all types, and that's something that we need to do as a wider social unit together, and then with people feeling empowered of whatever age to sit within themselves or make changes if they want, then the vulnerabilities and the dangers aren't there as much, and it will take the pressure off all the change needing to happen in these particular silos. That's me, thank you.
I was thinking about some of the similarities with some of the conversations we've been having, Joey, recently around gender affirming healthcare, and just the real value and gold in doctors who are prepared to kind of not necessarily know all the answers and be a bit vulnerable and be willing to work with someone as a partner in their kind of healthcare journey. And I think as part of this is that I'm feeling that the session is so short in terms of the amount of information that we'd want to get across, or the kind of need for these discussions, and really filling the gap in terms of what access to information medical students have in this space, because it's not necessarily covered that well in curricula at the moment, we're aware. And so, like, as a medical student and as a doctor, you're not necessarily going to know all the answers, and because we are talking about a whole range of different types of bodies and different conditions, and everybody is unique in their own way, like, people will present with different things and you won't always know what things are or exactly what to prescribe, or what exact dose is going to be the right amount of something to give them. And so, like, it is a process of being able to test different things out, and like checking with people what's working for them, and being able to listen to people's experience. And I think that's just so valuable when doctors are able to operate in that mode of not having to always be the expert who has all the answers and who someone can come to and just be like given things, because it is sort of an ongoing, I think, lifelong process of learning, and of learning from the people that you're working with as well. So that's my reflection on the way out, for what it's worth.
Love that, Moira. Indira, you're up.
I mean, I just feel like I was sort of a participant in this who just got to be on screen and watch you all deliver this. But I just wanted to say that it's super daunting being a medical student in the hierarchy, as everyone's spoken about, and I think I've already said about 5 different times. It can be really scary when you go up against people who are your superiors and seem to hold the keys to your future career. But I'd just like to point out that we all, as much as we feel that power difference, imagine what it's like for patients, and especially for vulnerable patients. And as much as, when a consultant isn't maybe doing right by you, you wish someone, you wish the registrar would say something, you wish the house officer would say something. Patients are hoping you'll say something as well. And so I'd really encourage you to think about ways that you can say something. Obviously, keeping yourself safe in those scenarios, but there's usually something you can do, even if it is small. So I'd encourage you to look out for that. Yeah.
Thank you. I feel like I've said my piece, and there are so many resources that we will circulate. A few people have asked about more resources, and Jelly has more to share as well. So we will be sending more out and putting more up on our website. Don't worry about that. Does that bring us pretty well on time for us to close the session? And thank you everyone for being here with us. Thank you for watching this as a recording if that's what you were doing, and thanks for attending live for our attendees who are here with us on what feels like very, very late at night by 8 p.m. We know how busy you are. We know that you are exhausted as we are, and the context of a pandemic is making everything so much harder for anyone working in health. So deeply appreciate anyone showing up for this work in any way, big or small. Yeah, thank you for that. Moira.
Kia ora. Yeah, and I just popped this slide up to say that the webinar recording will be up on our website soon, but also you can hop on and watch various other sessions. We've done a couple of other webinars around intersex issues in terms of support for parents and whānau, and there was one we did a little while ago, which was a conversation around bodily autonomy, sort of looking at trans and intersex issues and how they kind of compare and differ. So have a look at those, or there's various other sort of rainbow wellbeing topics up there as well. But just thank you all, as Joey said, for being here tonight with us on in this late evening. Really appreciate your time, and I'll just close us with a karakia as we begin. So me karakia tātou. Unuhia, unuhia, unuhia ki te uru tapunui kia wātia, kia mama, te Ngākau, te tinana, te wairua i te ara takata. Koe ara e rongo whakairea ki runga kia tina, hui taiki. Kia ora, thanks everyone.
Kia ora, thank you Moira. Ka kite.